Thank you, Mr. Chairman. I'd like to start thanking Professor Hosni for the kind invitation and the great effort being done by Sherif Omar and Sherif Tawfiq for this fantastic. I've been asked to give this talk, and I'll be throwing a grenade against all of you because it might change a lot of your views about a lot of things. And I have no conflict of interest. In fact, I'm going to try to get sense in what you're going to be told, and Hisham was the best preparation for my talk. Prediction of outcome and cost effectiveness of the first 1,000 AAA in repair practice volume. Best graft haven't been designed, but a lot of lessons learned. The remote is not working. We have a published paper today, which I'm going to show to you, and I hope you'll understand exactly where I'm coming from. And the whole idea that we're doing everything for the patient, but we have lost what we're trying to do in the essence of trying to achieve a fantastic completion angiogram. We are expanding the AAA horizon. We start using fenestration, branched, you name it, whatever we have done. Is it working? What we have done for the heart problem when they have all these patients developing cardiac failure, MIs, within 2 to 3 years of implanting a stiff tube in their aorta. That was the headlines, and this was in the Medical Device News magazine, and both of them are being quoting me and Frank Weiss. And what the idea was, UK criminalize IVAR, but don't be fooled. That's what the NICE guideline depending on. And depending on devices that was drawn from the market, the Medtronic, the Anurex, the Quantum, the Ancure, the LifePass. However, remember that the Gore excluder experienced significantly lower rates of complication and reintervention than any other graft available on the market. And now the whole idea is IVAR undergoing a paradigm shift. The SAG dynamics have always been a robust indicator of IVAR durability, but without distinction between stable and regressing aneurysm. And we know that if the aorta is stable, we're happy. If there's regression, we're happier, and expansion means a problem. However, all the studies show that there is a reason to differentiate between stable and regression. Regression will improve the survival and will have lesser mortality. Stable, still question what's going on, and this is an alarming finding that have just been discovered. What we do is we depressurize the sac so that there will be no leak, and we do an aneurysm remolding through the graft material. But the continuous seal suture and anastomosis haven't been met yet in any graft available on the market. And the hemostatic barrier with a polyester or dacron proven durability and thrombogenicity in these patients. The dynamic aorta demands continuous seal, and during the cardiac cycle, 35% greater area in systole versus diastole, so your design of the graft is a problem. And there is threefold increase in greater anterior wall motion versus posterior wall. At the same time, the posture-dependent endoleak cannot be diagnosed except when you do the CT scan while the patient is standing. And the continuous proximal seal in dynamic aorta is mandatory for depressurization, but we haven't achieved that at all. And you know that sac regression, sac expansion, type 2 endoleak is a problematic as we go in. I advise you to read this paper. It's just been published today, Contemporary Abdominal Aortic Aneurysms, 3 decades of research and development with big data. Why had the best graft haven't been produced yet? It's a missed opportunity, and you could see that Juan Parodi is one of the co-authors. The endograft must have an exoskeleton covered with an ultra-thin layer of PTFE, zero graft having that except part of the gore. Main body must be compromised ring stents rather than Z stent. All of them are Z stents. Oversizing and the distal sizing of the distal zone have to be above 15, and the iliac freight limb more than 24 must be abandoned because it causes problems. However, in the pursuit of market share, the companies compromise the fundamental science behind the design of a good endograft and jeopardize long-term durability to please the intervention cardiologist. However, they start releasing new graft with NASA technology in order to allow the healing and ability to adapt at the neck and to try to realign and refire the graft in it. Is that enough? We don't know yet, because this has just been launched last week, and hopefully it will change the problem that we're facing currently. You do a case like grade 1 or grade 2, and you said, oh God, I've done a complex case. In fact, you didn't. This is the simplest cases ever, and if anything goes wrong with this and you go to the court, you will be sued, because this is supposed to have less than 1% complication. Moreover, if you have to complicate the problem for you, and you said that you have done a complex graft, that's only grade 3. And the complication rate have to be less than 3% in doing such cases. And if you go in and you start doing that stuff, you have to understand that the endopaving and the coupling is crucial for a better outcome of your patients. Octopus AAAs could be done. You could get a fantastic outcome, but later on, as you can see over there, there's a graft fracture because of the ability of the stent to rotate and mal-rotate. With 90 degrees angulation, you could say that you have fantastic graft, but none of them are durable for the reason that we have mentioned before. So we start using the dress technique, which is design, reconfigure, elongate, straighten and stiffen, where you put a palmar stent before you do your graft, as you could see in here, and then you fire the graft after that. This will allow the barbs not to allow for any migration. And as you could see in here, again, we put the palmar stent in, and then this patient came with a rupture aneurysm and had an EVAR and done fantastically well. Accept no fears, no limits, and no excuses. But you have to understand the limitation of the technology in your hand as time goes by. And this is a patient came with aortoduodenal fistula. If you open him, he'll be dead on the table. However, we have put 2 stents, one in the inferior vena cava and one into the aortoiliac occlusive segment. If you have both common iliac arteries, just land in the external iliac and even don't think about the internal iliac at all, because there'll be no problem and the patient will do very well. This patient ruptured aneurysm and it was auto-transfusion to his inferior vena cava, so we have to put 2 EVARs, full EVARs, one in the inferior vena cava and one into the abdominal aortic aneurysm, and that's the follow-up at 54 months. But when you do all of that, you have to be well prepared for this disaster when you have this type 3 endoleak that everybody's trying to treat and you can't do. And the only way to treat this type 3 endoleak is to explant the graft. And that's my museum, and I'll tell you, it's not easy to get all that stuff out. And that's new anchor stuff have created more damage than benefit. And I warn you, if using it you think won't solve the problem, you will be swearing against you'll never use it again. Moreover, you have to know how to deal with all this complication and how to get all this graft that have a lot of barbs on, because it will cut through your hand when you try to get it out without the tricks of trying to put it through a syringe in order to prevent any problem. Also use pledges while doing your anastomosis, and be prepared for the ischemic bowel that you can't escape it, because whatever you're going to do, this ischemic bowel will chase you until the patient goes outside the hospital, hopefully alive. You always have this arterial stick, which created a problem for you, and if you didn't have it, you haven't done enough to see the complications. And we use, when we open the patient for a type 2 endoleak and the graft is perfect, we use the vas guard graft as an induced thrombosis around the area, because it creates a lot of inflammatory response for the patients. Everything that I've told you have just been published this year, and you could download that freely from the ResearchGate or from my LinkedIn, and it's available for you to read about it extensively. And we conveyed more than 1,000 patients over 20 years, and all of them been done equally proficient, both open and EVAR, using precision medicine with adaptation of graft type, configuration, and post-operative surveillance to maximize the individual patient. And the incremental cost-effective ratio for para-renal retrieve was 125,000 euros saved per quali gained. So this is our experience over the past almost 20 years. Total of 1,002 cases. And you could see that our 30-day mortality is 1.4 for elective and 17.8 for emergencies. And our open 30-day mortality is 2.8, and for open emergency is 26. Not too bad. If you look at the published data, it's very close to 45%. This is what we have used, and you could see between Gore, Cordis, Endurant, and I'm just going to highlight very important stuff. We found that highest limb thrombosis in the Graft. However, when they have moved their manufacture from Mexico back to the United States, that have abolished completely. I've only inserted 4 cooks, to which I have to explant 3 of them. And you could see that 6.8% died from MI, and 7.7% have died from malignancy. And you could see that malignancy is becoming to creeping the most commonest cause of death of such patients. However, we explanted the So improved outcome, similar aneurysm-related survival, no significant difference in quality, and EVAR is cost effective. Mr. Chairman, ladies and gentlemen, no difference in cost between EVAR and open surgical repair or cost per quality. Surgeon alone provide both treatment without the need for any intervention radiology team as mandatory in the UK center, which is a total disaster. And if anybody from England in here, I hope you're going to agree with that. Uses CTA only when duplex demonstrate increase in aortic sac diameter and decreased graft limb velocity with low long-term rates of intervention in both EVAR and open repair. Stop doing unnecessary CT scan. CT scan is not a mode of treatment. To increase applicability over the broad spectrum of aortoiliac anatomic configuration, you must at least master 4 grafts. You cannot use 1 graft for everything. It's a disaster. You will end burning bridges. Persistence of low rate of secondary procedure and aneurysm-related mortality will provide a minimally invasive solution that compares favorably with traditional open surgical repair. Investigation of EVAR or BVAR must only be executed during a course of clinical trial with a sturdy safety committee that can collapse the program when such ploys show harm, toxicity, and maltreatment to the patients. The problem that everybody coming to you talking about fusion imaging and CIDR and EVAR and BVAR, nobody told you how many then ended in renal failure, how many required not even to carry on to the end of the procedure or conversion. Avoid repair in octogenarians with thoracoabdominal aneurysm, as the majority represent an end-of-life scenario and require palliative care. Vascular surgeon must master by open surgical repair in high volume surgeon and center. This giant AAA do not offer them EVAR. It's a disaster. AAA must be repaired on a smaller diameter. If we wait for the trial to get below 5, it will not happen over the next 5 years. With precision design graft to ensemble patient from oversizing with minimal number of modular or limb components. As you can see, that is back to the future. We used to do a lot of open, we moved to endovascular, but we're going back to open now for a lot of cases. And patient choice now, they're well educated on the internet, and Mr. Google have done a lot of research for you. Thank you so much for the opportunity to present in Cairo. I really love this city.